There's no such center anywhere in the world. So bringing bright minds together, not only that understand diseases and can deal with patients, but can actually take this information and try to model it into a surrogate model that can be used to also screen for potential treatments is literally the goal. And that's why I'm here.
Hello and welcome to the podcast Hope and Help for Fatigue and Chronic Illness. I am Haylie Pomroy, your host. I am the Assistant Director of Integrative Medicine Program at the Institute for Neuro-Immune Medicine. Today I have an incredible guest. He is considered the world expert in mast cells, also the world expert in flavonoids. So we talk a lot about inflammation. And so today I'd like to welcome Dr. Theoharides. Welcome, and thank you so much for being here.
Well, it's a great pleasure, and I'm all excited to talk to you.
This is going to be fun. So I have a lot to ask you. I want to first start with, I have to calm myself down sometimes when I get guests like this. I want to first start about being at the Institute for Neuro-Immune Medicine. How did you get to us? Where did you come from? And then I'm going to ask you what inspired you to be here with us. We feel very lucky to have you, by the way.
Well, thank you very much. So I was trained at Yale University, from where I have about 5 degrees. So I was there for about 18 years. Then I was recruited at Tufts University in Boston, where I set up the Department of Pharmacology, did training in internal medicine. I was on the faculty for 33 years.
Oh, my goodness.
And over the years, I became very interested in complex, especially neurologic diseases. And I was very much aware of all the work my colleague, Nancy Kleinmans, was doing. So as I was getting tired of being in Boston, I and Nancy decided that maybe I should come down for a sabbatical, which I did.
When was that? How long ago?
That was 2 years ago.
2 years ago, okay.
And during that sabbatical, it was quite obvious they have a lot of common interest and a lot of enthusiasm for getting more things done. Especially in what we would call neuroinflammation, which is, of course, within the domain of Neuro-Immune Institute, so to speak. So I guess powers to be created a position for me, and a year ago I joined the faculty as professor at the Institute.
That's very exciting. I know we've all been talking in this podcast about some way or the other, Dr. Kleinmans bringing us all together. And I know that it was a very big victory for the Institute to have you join us, not only with your expertise, but there is a significant passion that you have with the patients that are dealing with chronic illness. And can I just ask you, it's not an easy path, right? This isn't something like curing an ear infection or a throat infection. This is a long, progressive, very complicated process. So where does that passion come from?
Well, over the last 15 years, I, and I'm sure many of my colleagues, have become aware of the fact that most of the diseases we're dealing with in this century are not the bread and butter of what we used to call medicine, like sore throats, rhinitis, maybe hypertension, etc. And these are diseases that we had never heard of while I was actually studying at Yale Medical School, like chronic fatigue syndrome, fibromyalgia, autism, etc.
I'm going to stop you really quick because
Sure.
I always say when I get the chills, you've said something that I know is going to impact our community. When you were studying medicine, these diseases weren't even identified yet.
Not at all.
Okay. That's profound. I mean, and it's a perspective from us as the patient that we have to understand how cutting edge being in research and clinical care in this field is.
No, that's absolutely true. I mean, the diseases probably existed. We're oblivious about them.
Right.
And basically what was happening then is what continued to happen and still does. Literally, patients go through as many as 10 physicians and as many years before they come up with maybe a diagnosis.
So the average patient, and we were just reading this statistic the other day in clinicals, the average patient will go through 10 practitioners and maybe 10 years before they get an accurate diagnosis when it's neuro-inflammatory, that umbrella under neuro-inflammatory. Okay.
So if I were to wear actually the hat that I had back at Yale, where I was a professor, of pharmacology, and then at Tufts was a professor of internal medicine pharmacology. After 50 years old, we encounter about 2 diseases. For each disease, we prescribe roughly 2 drugs, let alone all the supplements. For every 2 drugs, we have the risk of 25% of unwanted drug interactions.
Whoa.
So at 70 years old, someone is likely to suffer more from unwanted interactions rather than a particular diagnosis. And so go figure, if someone is going through from physician to physician, no one really understanding, most physicians would prescribe something just to get, quote unquote, rid of a patient because they don't know what else to do.
Right.
So by the time we see them, or I used to see them, they were so complicated that it took us, weeks just to untangle what was going on until then before we'd eventually do the right thing in terms of either diagnosis or management.
That's amazing. And so I just want to hear what I heard again, because it's kind of mind blowing right now when I think about the fact that oftentimes we're being treated, the symptoms being treated, because we don't understand the patient maybe fully.
Absolutely correct.
Yeah, and that our risk when we treat the symptom and not the patient is sometimes complications, right? Oh my goodness, okay.
I mean, I used to get, and I still get, it's just that I don't deal with these patients directly, about 10 requests a week for years and years and years of people that just don't know where to go.
Right.
And eventually, by searching, they will find either my name or the word mast cell or something relating from what they had been reading.
Right.
And they will reach out, for hope, for help. And when I talk to patients, and whenever I've lectured, whether it was a podcast or straight out lecture, I actually tell patients 2 things. Number 1, try not to look your best when you visit a physician, because if you look good, they don't believe you.
Oh
and
my
number
gosh.
2,
Okay.
don't go in someone's office with a list of 30 symptoms. Again, they're not going to believe you. Decide on the 3 worst symptoms that are really bothering you this week.
So create a hierarchy.
Get through the door, have someone listen to you, and then you can add actually all the variety of symptoms and other problems, because you really have to get someone's attention. And not only that, you've got to get the attention of someone who's willing to spend time with you to understand your problem, look at you as a human being, from a much more general perspective than a specific, specialty, if you wish.
So I can't tell you how validating what you just said is for me as an individual that's gone through, a lot of different practitioners, having an autoimmune disorder, dealing with things in my own particular health, how validating it is for me to know that I need to take steps in order to have a functional relationship with my practitioner and get the care that I need. It's really important to me. It's like it's the Institute. We come forward always with, first and foremost, we believe you, right, at the Institute. But for you to just, again, kind of give us permission to advocate for ourselves and to understand that if we don't, we're not going to get quality care is real. I just want to thank you for that. That's really important.
Well, medicine has evolved over the years, and in some ways, not for the best.
Right.
I mean, we have incredible research. We have some incredible approaches to treatment of certain diseases. But for the overall patient, we're not doing as well as we should have.
Right.
For instance, with complicated patients, we used to actually get a group of physicians to sit around a table and discuss the patient. Most insurance companies just don't cover the time for that, so that doesn't happen. Luckily, it happens at least every Friday at the Institute, and
Right.
We talk all the time. So that's really very important.
Right. So I want to bring that to the attention. So on Fridays, we have our Friday clinicals, which I don't care what time zone I'm in. It's one of my favorite parts of the day. You brilliant physicians and researchers and clinicians all come together and you share cases and phone calls, things that you've experienced. And that is not common at all. I have tons of, other practices that I work with. That's not common at all. But I can't believe the amount of solutions that come out of that meeting. It is invaluable.
True.
Just the resources. One of the docs will say, well, I tried this one time and I started this one time. Just that collaborative care. Right now, I'm going to just ask, you said the word mast cell. And I know that you are the world expert in mast cell. With chronic disease, with autoimmune disease, with neuro-inflammatory disease. Mast cells are a major character.
In fact,
a
they
major.
are.
Can you explain? And for me, please, pencils and crayons. Can you explain what? I want to say what all the hype is about. I mean, it's in so many articles. Help me understand it.
Let me start historically.
Okay.
So the mast cell was discovered by Dr. Paul Ehrlich in 1887 in his doctoral thesis. He was staining various tissues and used a blue dye, and certain cells turned violet. So he called that metachromasia, from the Greek change of color.
Okay.
He noticed that within the cell there were these violet little dots. He didn't know what those dots were, but he thought those cells were feeding surrounding cells. And using the word masto from the Greek word, which means breast, he called them mast cells, thinking that they were feeding surrounding cells.
Oh, wow.
In fact, that wasn't...
They're not feeding.
They're not
okay,
feeding,
okay.
but the name stuck. At about the same time, two scientists were operating out of the Oceanographic Museum at the Principality of Monaco. It was the principal scientist, and they did an experiment where they ground up jellyfish tentacles.
Okay.
And the idea was, if they were to inject them into dogs, the dogs will become immune to subsequent stings. And they had a word ready for it. They were going to call this phenomenon prophylaxis.
Oh.
So they went through the experiment.
Preventative, yes.
They injected the dogs, and the dogs died.
Oh, my
So
goodness.
they called it anaphylaxis.
Oh,
And that happened in 1901. So the mast cell and the word anaphylaxis were basically coned within a few years of each other, but it was not until 1947 when the mast cells were shown to include, synthesize, and release histamine that the word anaphylaxis and the word mast cell were tied together.
Okay. So does a
So
mast...
the mast cell is like a soccer ball filled with about 1,000 ping pong balls,
Okay.
each ping pong ball having about 50 marbles.
Okay.
So when a trigger comes, the mast cell explodes like a hand grenade. We call it degranulation.
Degranulation?
Correct.
Okay.
And
I'm going to get really
releases-
smart with this.
And releases all its contents, except that we mostly deal with histamine because that's what we understand best. So that creates the problem to begin with.
So histamine is inside of a mast cell.
Inside the granules of the mast cell, sitting, waiting to be released.
Where are mast cells in the body? All over the
So
place?
they're all over the place,
Okay.
very critically located next to blood vessels
Okay.
and next to nerve endings.
Ooh. Okay.
So the mast cell basically senses what happens on the outside world because they're plentiful in the eyes, nose, mouth, lungs, skin, gut. But because they're found around the blood vessels, they throw tentacles, philopodia, between the two cells that make up the wall of the blood vessel, and they sense what's happening inside the lumen as well.
Oh, wow.
So they're literally the first cell to be activated, whether it's an internal trigger or external trigger, and then orchestrates an immune response. And
So-
what is amazing is that they're found in the brain. The brain doesn't get allergic reactions.
That's what I was just going to say. Okay. So there's areas that they're located in the gut, in the nose, all throughout the body, close to the blood vessels.
Correct.
They are indicators of what's going to happen in the immune system, right?
Correct.
They help with
with
dictating
everything.
that.
Everything.
Okay. And then what's the difference between a person having a mast cell reaction and a histamine reaction? Like, so you see all the commercials and they say, take a histamine blocker.
Sure.
Okay.
So now imagine that the mast cell is releasing 50 molecules,
Yep.
one of which is histamine.
Okay.
So when we give an antihistamine,
Right.
we only hope to block the effect of histamine after it has been released from the mast cells.
Got it.
We do not have drugs that block the mast cell from releasing histamine
Exploding. Yeah.
and a whole bunch of other molecules,
Okay.
except for some of the flavonoids that you kindly mentioned at the beginning.
Right.
So we separate basically the reactions in 4 different types. So one is if the trigger is an allergen, in which case immunoglobulin E is involved, that's a typical allergic reaction, or sometimes we call it atopic reaction.
Okay.
Then you have triggers that have nothing to do with allergens. So there are patients that smell Clorox or perfume and they turn red
So they're
and
not
they blow up.
So they're not allergic. They don't have an immunoglobulin immune
Correct.
response.
Correct.
But they have some kind of a reaction.
Correct.
Is that a mast cell reaction?
Well, in most cases, it is the mast cell.
Okay.
And in some cases, we know how the trigger stimulates the mast cells. In other cases, we do
have
not
no
know.
idea. Okay.
And then you have a histamine reaction. So histamine can come from the mast cells, but it's plentiful in many foods.
Yes.
So foods like, cheese, avocado, tomato, spices, spinach. So histamine can come from the food or come from the mast cells.
From the body. Is it the same kind of histamine?
It's the same kind of histamine.
Okay.
And we have an enzyme that's supposed to break it down. But many people don't have that enzyme, or they have mutations, so the enzyme doesn't work very well.
What's the enzyme?
It's called diamine oxidase.
Diamine oxidase.
Many times you could call it DAO.
DAO, yep.
And that is important because if there are mutations and the enzyme doesn't work well, then whether the histamine comes from the food or the mast cells, you won't be able to break it down, and you will have a reaction. And many times, physicians and others confuse this histamine intolerance with the histamine that comes from the mast cells due to a reaction that triggered the mast cells.
So I want to do an entire podcast on, I want to do about 18 podcasts with you. One on food allergy, food reactivity. Why in the world is everybody allergic to peanuts now? When I was growing up, that wasn't the case, but it's definitely the case. We have so much more anaphylaxis in our world and in our environment. One thing that I want to understand is if we go to how important it is in neuro-inflammatory disorders with people with chronic fatigue, fibromyalgia, how can they start to have this dialogue? First, I want to know is, in your opinion, do you think statistically it's relevant in these people with chronic inflammatory diseases?
Very much so.
Okay.
So there's a few things that one can do. Number one, when you take a history, you've got to make sure that you ask the right questions that might indicate that mast cells are involved. Because if you say mast cell activation, patient will not know what you're talking about. If you say allergy, that might not be true.
Okay.
For instance, 60% of the people that are tested for the presence of an allergic reaction, whether it's measuring in the blood or doing skin testing, turn out to be negative.
Yeah.
But they are sensitive to foods. And in that case, it's immunoglobulin G subclass 4 that is involved and not immunoglobulin E, which is involved in allergies.
So you said Z is in zebra?
G is in George.
Okay. IgG.
IgG subclass 4.
Got it.
Okay. So first of all, there are two different conditions. And of course, you can't tell the patient that. So what you ask the patient is, from the time you remember, was there anything at all that caused itching, that caused your skin to be red? If you're in the shower and the shower is hot, do you turn red? If you go through customs and you have to go through duty free, do you freak out when you start smelling things?
Yes, the answer is yes.
So that already tells me.
Thank you, Dr. Harris, for asking me these very meaningful questions.
Because we tend to ask questions that don't make sense.
Yes.
Allergic doesn't mean something. Many people think allergic means allergic to drugs.
And to flip that, because this is what I see in my community a lot. Individuals come in and they use the word allergy. Mm-hmm. They say, I know I'm allergic to dairy, or I know I'm allergic to pineapple, or I know I'm allergic to avocado. I get itchy tongue, I get rashes. I went in, my doctor did an allergy test, and he said, you're not allergic. Mm-hmm. How does one communicate? Would the right term be then I have a sensitivity to it?
I guess from the patient's perspective, you will have to say sensitivity, or you will just describe the symptoms.
Okay.
My mouth
I have,
itches.
But is it correct to say I'm having a histamine response?
No.
Okay.
Because it might not be histamine.
Got it.
Many times it's histamine. But if you say histamine response, at least I think you're going to get to the right, next question, hopefully, from a colleague.
Okay, so here...
But there are two more things that I asked.
Yes.
Number one is, if you have black circles under your eyes and you haven't slept for 3 days, if you haven't slept, of course you're going to have them. But if otherwise you have, full refreshing sleep, and black eyes, we call them moonshiners.
Yes.
That indicates the mast cells are doing something.
Okay.
And the other thing I ask is, I ask, and I do this, over the internet as well. If you kind of remove your sleeve and you raise, your arm, if you scratch the underside of the arm, in about 1 minute, if that turns red, we call that dermatographia.
Yes.
That means the muscles are activated just to the pressure. There's no allergen involved.
Wow.
Just what I just said is like 80% of getting me to the right next step, meaning what to measure laboratory-wise.
So when a person has, I'm going to use the term mast cell activation, is that the cause of neuroinflammation? Is that the cause of chronic fatigue? Is it a player? Is it a role?
So now there are Another 3 steps I'd like to
I like the way I leap 20 steps ahead. I get
did
you.
just fine. First of all, the mast cells, as I said earlier, are found next to nerve endings.
Yes.
Which means that molecules released from the mast cell will activate the nerves, and molecules released from the nerves will activate the mast cells.
Got it.
So, for instance, there's a molecule called substance P. It's involved in pain. It is released from nerve endings, and it will stimulate the mast cells. The mast cells have at least 10 different molecules that will stimulate sensory nerves and cause itching, for instance. Histamine is one, but interleukin 31 is another one,
Yes.
just to give you an example.
Yes.
So by trying to address, let's say, chronic itching, chronic urticaria, by giving antihistamines, we're missing about 50% of the patients whose itching is not due to histamine.
So if we're out here right now and I'm going to call it land the plane in my own brain, because I am going down a million paths here. I'm going to lock the door, and we're going to do this for 3.5 hours straight. I want our community to understand that this is what we do as an institute, is we bring brilliant people to the table to have conversations about what in the world is going on in these complex diseases. And it's complex. And we think about it. We research, and we do what we call translational research, where it's patient-implemented protocol.
Correct.
As we're all sitting here, and promise me you'll come back.
I will.
Okay. And we're going to have a lot more discussion about this. Let's think about, I feel like I'm getting the real treatment right now, but if we're talking to our community and we're thinking about individuals that are dealing with chronic illness, chronic fatigue, environmental toxicity, chemical sensitivity. You talked about, I just walked through duty free, and I can only hold my breath for so long, but I just almost have a panic attack, or putting gas in my car, or things like that. When a patient walks through our door, we do just such a complex intake. If a patient's getting ready to go see their physician, the takeaways that I have so far is, don't try to minimize your experience. Like, don't get all shiny and buffed up and say, no, I'm fine, and walk out of there and go, gosh, I wish I would have gotten listened to and better care. The other is to really have a clear focus on your symptoms. And what I love is that you talked about, the rashing, the being able to write your name on your arm. All of those kinds of things are things that would be really important. I think the big aha I'm having right now is I had a huge disconnect between people minimize sometimes allergies and the massive impact that it can have on chronic disease.
Right.
And what I'm hearing you say is that those are really important to talk to your physician about, and that they can make a ginormous impact on whether you're going to get well or not.
As long as the right physician.
Okay.
Because they may mention everything that I said.
Right.
And an allergist might say, well, you were tested, you're not allergic, go fly a kite.
But this is what I mean by I'm not sure if you understand, there's not much that you understand, the gravity of the permission that you just gave me as a patient to feel empowered that someone that's life has been dedicated to this just told me that my symptoms are valid.
Correct.
And they're important.
Correct.
And so that can help me be a better communicator.
I mean, having hope is the beginning of the end. There's no question about it. And having hope, even by knowing that you're going to walk through the door and one or more health professionals will listen to you,
right,
is enormous.
Right.
Let alone hoping, again, that they will connect the dots where other people have missed them. So you go somewhere hoping, and with this institute, it's more than hope, it happens, that people will connect the dots and will ask the right questions, and they will not give up until they find a way to help you and not necessarily address the symptoms.
Right. We're a determined bunch. That's for sure. So this is why we're doing this podcast, right? Is because we know that it's very difficult to receive this kind of care when you have a complex disease or complex illness. So our goal is to let you know that there is hope. Let you know that we're holding out hope. Right. We're going to hold that. We're going to light that candle and keep it burning for you, right?
Absolutely. I see a major problem of sort of neuroimmune conditions is that they involve the part of the brain that is called hypothalamus.
Yes.
Which literally regulates most of the functions in the body without our actually being aware of them.
Right.
And then the amygdala that regulates emotions, behavior, fear. And it so happens that the number of mast cells in those areas are as many as we have in the skin.
Wow.
And yet the brain does get allergic reactions. And we were the first to show that the main hormone released under stress, called CRH, stimulates the mast cells on its own right and resets the reactivity of the mast cells to many other triggers.
Wait, I can you say that again?
Of course.
No, that was a lot for me to
so we've
process,
got-
but it was very important.
So we've got in the middle of the brain,
Yes.
right behind where the
Yes.
basically optic nerves cross.
Yes.
We have the hypothalamus
Yes.
that regulates most functions of the body, as well as regulates the pituitary, which releases most of the hormones.
Yes.
that we deal
Thyroid
with here.
stimulating hormone,
Everything,
ovulation
sex
hormone,
hormones,
sex
etc.
Yes, absolutely.
The hypothalamus releases a hormone called CRH, or corticotropin releasing hormone.
Okay.
That gets the system going. And we thought, at least when I was at Yale, they were teaching us, that it only shows up in the hypothalamus and it only stimulates the pituitary. Well, we were the first to show that it's released outside the brain as well as inside the brain and has many more functions than activating the pituitary gland, especially stimulating mast cells. So for instance, we've had many patients who might have been allergic to this and that, and then something catastrophic happens, car accident, major trauma, God forbid someone dies in the family. And now they're allergic, quote unquote, to everything.
Yes.
So we used to think, at least they used to tell us, oh, this is psychosomatic. It's not psychosomatic. We know exactly what happens. CRH is released, the mast cells receptors for CRH, they're activated, and the whole reactivity is reset now so that they respond to triggers that they never did. So we know exactly what happens, and translational research basically means to try to figure out why it happens and whether we can block it before it happens, rather than dealing with the symptoms after it's happened. And hypothalamus regulates fatigue.
That's just profound. The permission that you're giving all of us right now to understand our bodies, right? To close that gap between, and like you said, people thinking that things are psychosomatic.
Mm-hmm.
And I can't tell you in our community how many times people say, I was going along life, maybe I had a little reaction to a bee sting one time or something, a little bit of poison ivy, poison oak. I got in a car accident, I got divorced, something major happened, and now I have multiple chemical sensitivity. I can't, be exposed to that. So you have moved from seeing patients one-on-one to being in the research space.
Correct.
And I'm so grateful for that because in our institute specifically, we do a lot of what we call translational research, which is what you just led to. I think that kind of blew my mind when I first jumped in, just so you know, because in so many other aspects of research, there's such a delay between what we find in research to treating the actual patients. We have closed that gap remarkably. As we wrap things up, what and why the Institute for Neuro-Immune Medicine, from a research perspective, why did you land here?
Well, one, as I said, is because of Dr. Klimas.
Dr. Klimas,
Number
yes.
two, because she and many other colleagues think outside the box,
Yes.
more so than colleagues up in Boston.
Yes.
Number three, there was an opportunity, which hasn't quite materialized yet, but we're moving towards that, to create actually a center for neuroinflammation research.
Yes.
There's no such center anywhere in the world. So bringing bright minds together, not only that understand diseases and can deal with patients, but can actually take this information and try to model it into a surrogate model that can be used to also screen for potential treatments is literally the goal. And that's why I'm here.
And you just said exactly what I hoped you would say, and that is that there is a vision, and that's why we need support. That's why we are here to give support. But there is a vision that patients in desperate need can actually get care.
Absolutely, yes.
Absolutely, yeah.
And the important thing with the Institute is they can actually do clinical trials fast.
Yes.
You don't have to go somewhere else and set up the clinical trial. So the hope is, and we're going to be using some really top-of-the-art techniques to create surrogate models for these complex diseases, is that within a year from setting up the model, one can actually set up a pilot clinical trial, assuming that there's money to do that, of course.
Right. Well, I want to thank you for being here. And also,
My pleasure.
what a first full circle experience that I'm able to witness that you're expressing here at the Institute. coming from, like you had mentioned, seeing patients that these kind of complex diseases weren't even identified in, identifying them, being the world expert in the inflammatory aspect with mast cells and flavonoids. And we need to have a podcast just on flavonoids.
Sure.
But now taking that further and realizing and actualizing the dream and the vision that is so embraced here, which is great, which is to have a place where we can actually see what works, both from a computational biology perspective, from an inpatient perspective, and get the help actually to the patient.
Well, let me give you an example. We've known that many patients, as many as 50% of patients that got sick with COVID,
Yes.
develop chronic problems.
Yes.
We call them post-COVID sequela or long COVID syndrome, etc. But we at the Institute become more aware probably than anybody else that many of them have quote-unquote allergic-like problems.
Yes.
So the question was, why? And we just published a month ago a paper showing that recombinant coronavirus spike protein stimulates the mast cells
Wow.
and stimulates the defenders of the brain called microglia. So there are two ways now that we can explain how, in fact, these patients develop symptoms that are reminiscent of mast cell activation when we didn't know the trigger. Had we not been able to ask the question and then do the experiment and, of course,
And
publish
do it fast.
and do it fast,
Yes.
no one would know. Now
Right.
that we know, it's easier to convince other colleagues to pay attention to the mast cells because there's a connection.
Yes. And also then to apply treatment.
Of course.
Well, Dr. Harris, I cannot thank you enough for being here with me. We are going to have many, many more conversations. As a community, you guys, we are in a very unique position to be able to ask individuals like Dr. Harris all kinds of questions. Make sure that you post, you comment, you let us know what you want me to ask him next time. Again, thank you so much. It's always an honor to share air with you.
Thank
let
you
alone
very much. It's
to
a
get to ask you
great
these
opportunity
questions.
to get this information out.
Yes.
And I congratulate you for the effort.
Thank you so much.